Good afternoon, everyone, and welcome to the last Friday lunchtime lecture for this term, which is kindly sponsored by Cambridge University Press. My name is Rumiana Yotova, and I'm a lecturer in international law here in Cambridge. And it is a real pleasure to welcome with me today Professor Matianke Sirleaf. She is the Nathan Patz Professor of Law at the University of Maryland School of Law, and she writes and teaches in the areas of global public health law, public international law, international human rights law, international criminal law, and post-conflict and transitional justice and criminal law. She will talk to us today about the very pertinent but underexplored topic of race and COVID-19. Now, if you have any questions during the talk, please enter them in the Q&A section at the bottom right corner, and we will try to answer as many questions as possible. So, Professor Sirleaf, over to you.
Thank you so much for that kind introduction. I believe you all can see the PowerPoint screen. Okay, that's great. So thank you for that kind introduction. I'm really excited to be here with you all today, virtually. I didn't know I was the last one. I hope not the least, but I'm glad to be here, sort of rounding out and closing out the series and talking about a topic that is near and dear to my heart. So thank you all for the invitation, and thanks to everybody who's joining the webinar. And so I wanted to begin today's discussion by taking a look at a couple of comments that were made last year around April sometime. And the quotes that you see are from two French doctors who appeared on television and discussed the potential of utilizing African subjects in experimental trials with the tuberculosis vaccine as an antidote to the novel coronavirus, COVID-19. And the outcry after this exchange was swift. You had the Director General of the World Health Organization denouncing these kinds of racist remarks as a hangover from colonial mentality. He maintained that, Africa can't and won't be a testing ground for any vaccine. The fallout on social media was also quite stark, with Samuel Eto'o, a Cameroonian football legend, referring to the doctors as des assassins, and several others questioning the motives behind testing a vaccine on the African continent. This discussion between the doctors and the backlash that it provoked, I think, is revelatory in the way that racism and neocolonialism are sort of reflexively invoked, and the ways in which, the casual way in which they talk about using Black people, Black bodies, for experimentation in ways that would potentially harm them. And so in this lecture, I want to connect the racial and colonial logics that are sort of reflexive, and reflect on how we see this across different areas of global health law and policy. And my lecture is going to touch on the racialization of diseases. It's also going to touch on the racially disproportionate impact of COVID-19. And then I'm going to conclude by talking about the inequitable vaccine access that we're also witnessing with COVID-19. And what I have seen with COVID is a real prism of structural racism. It has rendered quite glaringly bare all of the underlying fissures in society that fall along racial lines. And this is certainly the case domestically in the US, but we're also seeing this across the globe across the globe. And so let's move to talking about the racialization of diseases and the work that I've done in this space. And so COVID-19, we have seen the resurfacing of outdated but persistent settler colonial conventions that have sought to map illnesses and diseases onto racialized people and to certain geographic diseases. In particular, the 19th century strain of thought that maintains that all things Asian are a sort of a threat to the Western world has been apparent with COVID-19. A newspaper in France actually ran a headline titled, quote unquote, yellow alert. And we have seen an uptick of attacks on people that present as Asian from London to San Fernando. We've seen people that present as Asian being racially profiled, children trying to test other children for coronavirus. And we've also seen the response by institutions to try to normalize xenophobia and racism as sort of understandable reactions to COVID-19. And this mapping of diseases onto the progeny of particular countries is tied to historical ways in which racialized anxieties of the alien and the other and their illnesses has occurred. And the former president of the United States in particular would constantly make racist and inaccurate references when talking about COVID-19. You have undoubtedly heard of the quote unquote Wuhan virus, the quote unquote Kung flu, and the quote unquote Chinese virus. And again, all of these things tie back to the othering and denigrating of Black, Indigenous, and other people of color as infection prone, as afflicted with exotic sicknesses, and as sort of just generally unhealthy. And in the United States, we can go back to when the bubonic plague hit in San Francisco at the beginning of the 20th century, where you had Chinatown forcibly quarantined because it was considered unclean by the authorities, and the residents in that space were not able to go to work. They were going hungry, and it was difficult for them to exist. And so the association of people of color with various maladies, or what I've referred to as the racialization of diseases, is a way in which racial meaning is attached to ailments based on the racial groups that are supposed to be socially associated with that given illness. Of course, this has nothing to do medically with how diseases operate, but there is this long history of othering people of color as disease. For example, with Black people in the United States, we were considered notoriously syphilis soaked, while when white people contracted diseases like polio, for example, was because, oh, well, their bodies were complex and delicate, and that's what rendered them susceptible. And so this social construction of racializing diseases is not something that microorganisms actually do, right? Microorganisms do not differentiate amongst their victims based on race, on nationality, on ethnicity, or other categories. And so while it is the case that microorganisms do not discriminate, societal actors, individuals, institutions, and the like do via direct and indirect action. And we've seen this made glaringly so with the COVID-19 pandemic. And for instance, the failure to protect historically subordinated groups has meant that Black people in the United States are dying at approximately 1.5 times the rate of white people from COVID-19. Latinx communities are also dying at significant rates higher than white people in the United States. The number of Black lives lost account for nearly 20% of the deaths across the United States where race is known, despite Black people not making up 20% of the population across the United States. And so these glaring racialized health disparities is not the result of innate susceptibility of marginalized groups, but instead reflect structural racism. And so COVID-19 and that pandemic and the pandemic of systemic racism have reached a heightening visibility because of the ways in which the subordination of people of color are laid bare. And I want to tie this current moment where you see the heightened visibility of the subordination of people of color to a time where the emergence of the global health regime began, because the racial subordination that is ongoing is steeped in a history of racial subordination, and it's important to understand that. And so today we talk about global health, and so I want to trouble that, because the founding of global health was really the founding of white health, and a concern for white people. And in particular, European colonial powers formulated the global health regime to try to perfect the colonial project. The early efforts at global health cooperation by European powers were all premised on trying to contain racialized threats of diseases from colonized peoples. And so at the same time that European powers were competing for territories across the world, they found a way to cooperate to create treaties to contain diseases because it would help them further their imperial projects. And so you had no less than 13 international treaties relating to cooperation on health control measures. This is striking, for example, when you think about the ways in which British colonials in 1793 were giving Lenape emissaries items from a smallpox infirmary to intentionally spread diseases to nearby indigenous peoples. And so the incongruity of the settler colonial project spreading diseases that decimated native and indigenous populations, while at the same time negotiating and formulating treaties aimed at protecting the metropole, is telling. And so this is at the very first treaty, the International Sanitary Conference was convened. And the danger at the time was cholera. And at that time, there was concern that cholera would travel from India. It had reached Russia. And so the entire 1892 Sanitary Convention relates to cholera and trying to contain cholera from spreading from India to Europe. Similarly, in the 1897 treaty, the Sanitary Convention, that followed an outbreak of the plague in India, and Europeans feared that Muslim subjects in their colonial territories might become infected and then bring the plague back to them. And so subsequently, you had the 1897 International Sanitary Convention, which prioritized the plague as a disease that was warranting of international attention. And so this Eurocentric focus of the early global health treaties is repeated time and time again. We see this in the 1903 convention. White Europeans at the time initially regarded yellow fever as something that was a minor concern limited to the Americas. And so in the 1903 convention, of the 184 articles, only one pertains to yellow fever, while the other concerns plague and cholera. But as the different diseases came to impact European peoples, those diseases rose in importance in the global health agenda and in global health treaty making. And so when the influenza pandemic happened between 1918 and 1919, there was a sentiment that it was impractical to impose quarantine measures on the influenza pandemic. And so you did not see that disease accounted for in the Sanitary Convention of 1926. Instead, that convention focused on things that they thought could be controlled through quarantine, such as cholera, plague, yellow fever. And at the time, there was an outbreak of typhus in Poland and the Soviet Union. So you had the inclusion of that disease in the treaty regime. And so this expansion of the list of diseases that deserve international recognition under global health law coincided with the salience that Western capitals gave to those diseases. Imperial powers focused on creating global health as a regime to protect the colonial metropole. And it was not the case at all that these are the only diseases, for example, that were impacting the world. And it wasn't until 1944 that you saw any attempt to account in the global health system for reports of diseases that were not already prioritized by white majoritarian interests in Western capitals. And so this history of global health is important because it situates us in the current moment. And it's important to think about the ways in which you continue to see the center being prioritized over the periphery, the quote unquote periphery. And so the creation of the World Health Organization is supposed to represent a break from this colonial past. The World Health Organization, founded in 1946, is committed to the principle that all people are supposed to enjoy the highest standard of health, that this is a fundamental right of everybody, of everyone who's a human being. And this is supposed to be without distinction of race, religion, political belief, economic or social condition, and the like. Health of all people is seen as a principle that is fundamental to the peace and security of individuals and states. And so what we see in the transition to this away from sort of explicit colonial treaties is race playing a more subtle role, but a significant role nonetheless. The current treaty that is governing in global health that is most important for thinking about infectious diseases is the International Health Regulations of 2005. And that treaty aims to prevent and protect against the control and provide a public health response to the international spread of disease. That treaty makes clear that public health measures should avoid unnecessary interference with international traffic and trade. And so what is clear is that the regulations and global health relationship to trade and the prioritization of maintaining trade is something that lingers from the importance of global health placed on by European powers during the colonial project. And what is silent in the International Health Regulations of 2005 is race, what attention should be placed to race and to racism, particularly given this history of subordination in global health that I've been referring to. And so the IHRs of 2005 do not specifically refer to historic or ongoing racial discrimination in public health or medicine. And the regulations give a fair amount of latitude for states to make choices that can be influenced by racism. And there is a way in which the privileging of Western interest remains central in global health. And this can be seen in how you declare or when and which populations are worth declaring a public health emergency for, where you see epidemic spreading. And here I'm thinking mostly about the Ebola epidemic that took place in West Africa, to vaccine access, which is what I want to focus on today for the remainder of my talk. And so what I would like to talk about when we're talking about vaccine access is really vaccine apartheid. And as you can see from the map, there is a stark difference in where you see doses administered and where you see doses not administered in ways that fall along global south, global north divides, roughly. And so this vaccine redlining, though, is also taking place within the global north. For example, in the United States, many distribution centers have been located outside of communities of color. For example, officials in Dallas County actually had to stop a plan that prioritized COVID-19 vaccine doses for people living in most vulnerable zip codes after the state of Texas threatened to cut the county's vaccine supply off. Where there is data for states that track vaccination data by race, it indicates that COVID-19 vaccines are primarily going to white people, despite the fact that the pandemic is ravaging communities of color disproportionately. And so the number of vaccines within the global north are also falling on racially inequitable lines. And this is mimicked globally as well. And so globally, the way in which redlining is occurring is such that certain places are not expected to receive significant doses of vaccines until as late as 2024. Now, some of this delay has been, can be accounted for by limited supply, but that limited supply, I want to bracket that because there's an artificial scarcity that has been, that is creating that limited supply because of the monopoly power that has been given to pharmaceuticals who are developing the vaccines. There's also attention to lack of production facilities and logistical impediments, such as many of the vaccines needing sub-zero temperatures or refrigeration facilities, which will require a cold distribution chain for vaccine administration that may not exist in a number of places. But more important than the sort of logistical difficulties is the international lack of solidarity, and instead the vaccine nationalism that has occurred with COVID-19. And I think these are all sort of euphemisms for describing what is happening. What we've seen is countries in the global north prioritizing and competing for bilateral deals and hoarding enough supplies to vaccinate their population several times over. This hoarding of vaccines drives the prices up for other countries and makes it inequitable for them to access those vaccines. We've also seen restrictions by the European Union, which has authorizes member states not to even to put limitations on exporting the number of vaccines outside of the European Union. And some analyses have shown that rich countries are on track to hoard over 1 billion COVID-19 vaccines. And so at the same time, wealthy countries have failed to adequately support and fund global health schemes that have been created, like COVAX, which you may have heard of. Now, COVAX is the main initiative of the World Health Organization to provide COVID-19 vaccinations to people in low and middle income countries who are predominantly people of color. But it is unseemly rather, and unjust for wealthy countries to hoard vaccines, to drive up the prices, and then make it difficult for other countries to acquire vaccines, and then at the same time make promises of sort of charitable donations that are not forthcoming and that are ultimately going to be insufficient anyway. For example, even if the COVAX initiative were fully funded, a philanthropic model that relies on the munificence of others to donate money or to share vaccine surpluses is fundamentally flawed, given that there is a need for countries to vaccinate entire populations. A charity model where the charity model runs into problems because it's still based on this protection of the 20-year monopoly profit for pharmaceuticals. And so how do you plan for a vaccine drive based on the generosity of others, which can, be fickle, can go away. Instead, countries want to be able to acquire the vaccines themselves and know what their supply is for, a given period of time and for their populations in order to plan properly. Ghana, which is the first country to have gotten a vaccine, underneath the COVAX scheme, received enough supply for just 1% of its population, and only received that dose in late February of 2021. And again, we know that with vaccinations, we're trying to achieve herd immunity through the vaccines. And so 1% is not going to get you anywhere near the amount of protection that one needs to really be able to fight against COVID-19 through vaccines. COVAX also depends on extant power relations internationally, which are skewed in favor of the pharmaceutical industry and countries in the global north where most of the production of vaccine doses is taking place. And so here I want to introduce a concept of medical neocolonialism because it's instructive. And that concept characterizes the pattern of extracting resources from Black and other people of color. And the knowledge generated from that research is then subsequently taken for the development of new treatments and drugs, but the subjects and communities generally don't share equitably in the benefits of the new drugs or treatments. Medical neocolonialism as a concept draws on many of the characteristics of historical colonialism, in that medical neocolonialism is similarly driven by economic dependence, exploitation, inequality, and treating communities of color as disposable. And here I want to use South Africa as an example because it's one of the hardest hit countries on the African continent. And it's also one of the first countries to try to get vaccines on its own outside of the COVAX initiative, for example. It obtained millions of doses at a cost of $5.25 per dose. This is more than double the $2.16 per dose that European Union countries paid to the manufacturer AstraZeneca. And so I want to pause to talk about the Oxford AstraZeneca vaccine, because this vaccine is the one that was developed with an eye towards quote unquote developing countries. This was supposed to be the vaccine that was supposed to be used in developing countries. And at the time, the developers said they were going to, open the tech and all these things, and they've taken walked some of that back. Importantly, South Africa allowed a number of South Africans to participate in clinical trials for the development of this very vaccine. And what should happen then, as a part of sort of research guidelines, is that South Africans should have greater post-trial access and benefit sharing as a result of the vaccine being developed on their populations. And what has happened is actually the opposite of that, right? South Africa has actually has less favorable terms, more than double less favorable terms than other countries. And even worse, South Africa has a variant of the disease where the AstraZeneca vaccine has proven to be less effective against. And so South Africa then is left with having spent money for a drug that it ultimately will not likely be able to use, and has actually suspended its reliance on the AstraZeneca vaccine for its vaccine drive, and is moving towards considering other vaccines for its vaccine drive, given the lower efficacy of this particular vaccine in South Africa. And so this vividly illustrates the concept of medical neocolonialism, and it actually reflects an observation that Paula Farmer made in the ways in which the fruits of medical and scientific advances are stockpiled for some and denied to others. And so I want to briefly discuss the role of the international intellectual property regime here. And I would be remiss if I did not, because it's severely compounding the challenges of equitable vaccine distribution. As I referenced earlier, there's a 20-year monopoly for pharmaceuticals. This 20-year monopoly is granted by the international intellectual property regime. However, until the creation of this regime, many countries did not place any patent protection on pharmaceuticals. So this was not how things have always been. It's the creation of the trade related aspects of international intellectual property rights agreement and the ratification of this regime through the Doha Declaration that has functioned to expand and increase US style pharmaceutical patent protection globally. And so within the TRIPS regime and the Doha Declaration, there are supposed to be a number of provisions that allow for flexibilities if there is a public health emergency. But the proof is sort of in the pudding, if we could use that euphemism, because these provisions have had sort of a limited effect, and we're seeing that in trying to get access to vaccines with COVID, which leads me to the current dispute that's before the World Trade Organization TRIP Council. And again, there's supposed to be a public health exception that allows for waivers and other things that will allow countries to produce drugs and medicines without attention to some of the very strict patent protection that's embedded in the international intellectual property regime. And so India and South Africa recently put forward a proposal in October of 2020 requesting this, right? Requesting a waiver of the implementation, application, and enforcement of these TRIPS provisions that require patent protection for pharmaceuticals. They argued that the waiver is needed to prevent, contain, and treat COVID-19, given the acute health shortage faced by many countries. India and South Africa request that the waiver continue in effect until widespread vaccination is in place globally and most of the world's population has developed immunity. Their joint submission seeks to substantially reshape the TRIPS regime and allow for deep technology transfer for effective COVID-19 vaccines, therapeutics, and diagnostic tests. And so I want to briefly mention the limited supply here. So part of why there's a limited supply of vaccines is because the tech is closed, right? So if you were to share the tech that was used largely with public funds in academic settings to develop the mRNA vaccines and the like, with other producers, you could produce a lot more. But instead, we have a handful of producers protected by the patent regime who are able to create limited supply because that helps to drive up their profits. And so what South Africa and India are arguing is to, in effect, open the tech and allow more production of these vaccines. And so their argument is, this temporary ban will allow for the production instead of limiting manufacturing to these small patent holders, and it will enable the vaccines to be that much more accessible. This proposal has found support from the African group of countries and other countries in the global South. It has a total of 57 co-sponsors right now. Unsurprisingly, the pharmaceutical industry opposes this proposal, and a number of wealthy countries in the global North oppose it as well. Namely the United Kingdom, the United States, the European Union, and others oppose the proposal to waive intellectual property rights even temporarily. The countries opposing the waiver account for 60% of the globally administered COVID-19 vaccines to date. And so you can see sort of the darker areas on the map. And on their view, intellectual property rights are not a barrier to access. The current system is required to incentivize new inventions, and they maintain that equitable access can be achieved through sort of voluntary licensing and technology transfer agreements. And we've already paid some attention to how voluntary transfer arrangements like COVAX are facing much difficulty. There's a huge funding gap that COVAX is facing. And even if it's fully funded, it's not clear that that can meet the actual health needs of people around the world who lack access to vaccines and are living in vaccine apartheid. And so as South Africa put it in its intervention, the problem with a philanthropy model is that it cannot buy equality. And so the IP waiver request by South Africa and India was on the agenda for the TRIPS Council meeting that was scheduled this week. It was actually held on the 10th and 11th of this week. And there's been a failure to reach consensus again on this waiver proposal. And the agreement, I guess, is to consider the measure at the next scheduled meeting in June, and maybe to discuss it twice before then. While this impasse is taking place, at the TRIPS Council, this is the current state of the world with respect to COVID-19. You can see the number of deaths that have happened globally, and the striking number of cases that have happened globally. And so it is important to note that even outside of deaths, which are astronomical, the life after COVID, for many, your quality of life is drastically reduced than it would be if you had never encountered COVID. And so it's important that people have vaccines that can protect them from COVID-19. And so you can see the countries with the most amount of cases, the US, of course, leading in the number of deaths and the number of cases. But you also have India and Brazil not that far after in the number of cases. And particularly you can see the United Kingdom is very high up there in terms of the number of cases, particularly when you consider the small size of the population comparatively to the other countries that are in that list. And so this is where we are as of today with COVID-19. And so the Director General of the World Health Organization has warned that the world is in effect on the brink of a catastrophic moral failure, and that the price of this failure is going to be paid with the lives and livelihoods of the world's poorest countries. And I want to paraphrase that, and to be clear that the price has been and will be paid and be borne by the lives of racially subordinated people. And so if the current course is not corrected, vaccine apartheid will deepen and exacerbate the subordination of racialized groups and render them and us even more disposable. And this exacerbation of racial subjugation may not be the intention of law and policymakers when designing the intellectual property regime, or when thinking about global health and structuring legal incentives for research and pharmaceutical invention and the like. However, all of that is immaterial, because the impact of the system's effect on further entrenching racial subordination is acute. And there is an obligation on actors to remedy the inequitable disparities that we see with COVID-19, to remedy the inequities in vaccine access that have resulted with COVID-19, to correct the racialized health disparities that we see with COVID-19. And I think this lecture is a powerful reminder of how the history of diseases and the ways in which we respond to diseases is linked to colonial and ongoing politics of racial exclusion. And it's important to think about these things intersectionally. Traditional analyses may not capture how multiple areas of subordination, be it race or class or geography, may function to produce heightened subordination or gender also, amongst other categories. And so conventional analyses that fail to account for race obscure the functioning of histories of subordination, and do a disservice when you're thinking through questions of access to vaccines. And so this is not just a question of a market failure or sort of a political economy approach that doesn't take into account the ways in which that market failure is disproportionately impacting people of color, not just sort of poor people, and how that is tied to long histories of exploitation, of dispossession and devaluation of the lives of Black and Indigenous and other people of color. And so the COVID-19 pandemic and its responses to halt it have created a different world in some sense, but have also shown how much the world remains the same. And the need to address racialized global health inequities and address vaccine apartheid is going to require a significant amount of legal reform and restructuring to counteract years of entrenched racial subordination. And so this lecture makes clear, I hope, that while the COVID-19 pandemic has revived stereotypical colonial imaginations of where diseases come from and who are diseased, it's also simultaneously challenging racialized hierarchies of disease. And this duality, I think, is important to help us rethink and reshape the relationship between race and global health. And it opens new possibilities for anti-subordination efforts. And so I will stop the lecture portion of this and look forward to your questions.
Thank you so much, Professor Sirleaf, for this absolutely fascinating and very thought-provoking presentation.